don't know when it starts. So I'm going to start talking now. Okay. Hi, welcome to Fertility Talks. My host. Holy moly, you get things going and I mess it up, so it's okay. Welcome to Fertility Talks.
Hi.
I'm Mary Wong, your fine host of this evening. I'm a registered traditional Chinese medicine practitioner. If this is your first time tuning in, I'm the author of Pathways to Pregnancy. I'm the founder of Alive Holistic Health Clinic in downtown Toronto, and I'm your fertility coach. And tonight, I'm so excited to have with us Dr. Marjorie Dixon, who is also my friend and former surgeon as well.
I've been in your pelvis.
Yes, she has seen my,
innards.
You know what, the JJ and like everything.
It's all good.
It's all good. But tonight we're going to have an amazing topic. It's very insightful. We were already talking for like an hour prior to this, so it's going to be an awesome chat. And but before we do so, we're talking about PGS, by the way, and basically that means it's about chromosomal testing, genetic testing, all right, during IVF. So before we go into questions, we're going to share with everybody who you are outside of seeing my vajayjay.
Okay.
She is the CEO and founder of Anova Fertility in Toronto and is a graduate of the McGill University School of Medicine. Her initial postgraduate training was in the University of Toronto in obstetrics and gynecology. She completed her postgrad training with a 3-year subspecialty, American Board of OBGYN. I can't, it's just too long. Okay, obstetrics, fine. Accredited fellowship in reproductive endocrinology and infertility at the University of Vermont. Dr. Dixon is an active member of the Department of Obstetrics and Gynecology at Sunnybrook Health Sciences Center. So, now we're done with the formal intro and we're going to have a lovely chat.
Sure.
Okay, cool. So, very first thing, people hear of PGS, and we're talking PGTA.
Yeah.
So what exactly is that? First of all, not everybody knows PGS, so maybe we should...
So PGS is traditionally, the definition is called pre-implantation genetic screening. So before embryos are put back, so pre-implantation, before we put them back into the uterus for an individual to potentially get pregnant, we can screen those embryos for genetic abnormalities. So pre-implantation genetic screening, they gave it a new name called pre-implantation genetic testing for aneuploidy. So when you're looking at embryos and you're talking about genetic normal results, that means it's called a euploid embryo. Normal genetics is euploid. Abnormal genetics is aneuploid. So when you're pre-implantation genetically testing an embryo, you're testing it for abnormality, which will help guide you in as much as, would you transfer this embryo? Is your patient likely to get pregnant with this embryo? Or should you not transfer this embryo?
Very good. And you know what? I'm just going to back it up a bit for those who have no clue about what we're talking about, because some people are not at the stage of even doing in vitro fertilization, which IVF is, right? Right.
So you want to know, when we're talking about testing of embryos, that is when we have actually created human embryos outside of the body in an embryology lab. We have retrieved eggs, so individuals are trying to get pregnant and they're not getting pregnant by traditional means or with the lower level interventions such as insemination, which we often hear people say it's turkey baster, where you take the sperm and you actually insert it into the uterus. That's a lower level intervention. When you're getting to the higher level interventions, which we consider assisted reproductive technologies, that's where we actually employ other technologies to effect fertilization, so to make an egg and sperm come together, and then to grow them together into a human embryo to a place where then we will be able to transfer it into a uterus, or a woman's womb, and make a baby. When we want to decide, when we're trying to select which embryo is most likely to create a pregnancy in the shortest amount of time, traditionally what we have done is we've employed morphologic, which means we look at how it looks and then we decide based on characteristics that we know. So are the cells of that embryo clear? Are they evenly distributed? Did they divide in such a way that they are likely to implant? That's called zygote scoring. So we use what we know as we watch them grow and as we watch them either arrest or continue to grow for 5 days to the blastocyst stage to determine what we think about the quality of the embryo.
Right.
That's the traditional way. Now we have an advanced way of testing the embryo, which is actually taking some of the cells off of the embryo that's there.
And how many cells do you take out?
All right, so when we're talking about the blastocyst, so after 5 days of development, sometimes 6 days, we look at the extraction of between 4 to 11 cells of what's called the trophectoderm. So in English, when you're looking at an embryo, it's a ball of cells. There's what's called the trophectoderm. So if you think of a soccer ball, it's like that, the outer ball, the other covering cells.
The black and white ball.
Mosaic.
Yeah.
And then you look at the inner cell mass, which is a ball of cells that's inside that ball, for example. That becomes the baby, otherwise known as the inner cell mass. When you're doing or employing the pre-implantation genetic testing, what the embryologists or the laboratory specialists are doing is that they are taking a sample of those trophectoderm cells, of the outer part of the soccer ball cells. And
so not the baby.
Not the baby, the things that become, the cells that become the placenta and the membranes.
Yes.
Okay? And then each one of those cells has its DNA message amplified so that it can actually be looked at properly. And then it's chopped up and run on a sequencer. The sequencer that we use now, so we used to have different ways of testing, but the most up-to-date way of testing is called next generation sequencing. And next generation sequencing is part of what we call whole genome amplification. So we're actually looking at the entire group of chromosomes that we have. So humans have 22 pairs of autosomal chromosomes, the chromosomes that make you look like me and you like you. And then 2 sex chromosomes that make me a girl and you a girl. That, I guess, chromosomally XX, to be clear. And we're not allowed in Canada, at least, to know the gender of what we are looking at, but we can know the autosomal chromosomes, and then it allows us to identify, are there 1 too many copies, so that's called trisomy, or is there 1 too few copies, so that's called monosomy. And we also are able to detect at which location of those 22 pairs of chromosomes that abnormality is occurring, and then we can make extrapolations in as much as, yes, this is an embryo that's likely to implant, so it's either euploid, normal genetic, or it is aneuploid, abnormal genetic, so you shouldn't transfer it. And then there's this interesting population of embryos that we consider mosaic. And mosaic means that there are somewhere between 20 to even up to 80% of those cells that are abnormal, so that it's unclear whether or not it will implant or not. And much of the controversy around pre-implantation testing, genetic testing for aneuploidy, is, does this test really make a difference in take-home baby rates? So are women more likely to get pregnant when you have a normal genetic embryo transferred?
Okay.
Or are they less likely to have a miscarriage? Do they shorten their time to pregnancy? If they have recurrent pregnancy loss, are we able to identify interesting things like translocations and reasons why that's happening so that we can actually pick an embryo that's healthy and minimize the risk of miscarriage? So there are many studies and many opinions as to whether or not this test is useful. But what we are seeing in the larger studies with lots of numbers of patients that have been done in larger centers that do the preponderance of their testing, of testing of the embryos before they put them back, is that there is a particular group of women that seems to benefit from this testing.
Which is?
So once it's stratified, they do 30 to 35 years of age, 35 to 40 years of age, and then greater than 40 years of age.
Right.
It appears that the women that benefit most from this test are in the 35 to 40 age group. Okay? There is also a population of women who are in the older age group who, if they make a good number of embryos, so if they make 4 to 5 embryos, who also benefit, because we understand that as women age, the likelihood of making an abnormal embryo is greater. And so in the old days when we kind of looked at them under the microscope and said, oh, morphologically, the way under the microscope we see them, and based on their zygote scoring, we kind of feel like this is probably the embryo that's going to do best.
And so I'm just going to bring it home to you and make it real in your own personal experience. because I was part of that older age group in terms of the olden days, actually. Olden days and older age.
Yeah,
and in the olden days, with my older age, there was no opportunity given to me, even though this testing has been around, but certainly not so prevalent at the time in Canada.
And actually, I need to take it back further.
You take it back further?
Because there was a time where we were not able to do the testing at this degree of development.
Yes,
because
absolutely.
we weren't able to grow embryos out to the blastocyst stage.
That's right. That's right.
Back when we were playing, they were called blastomere stage embryos, so that were day 3 or cleavage stage embryos.
That's right.
And that's after 3 days of development in embryo culture.
Yeah.
There is a much greater rate of mosaicism, and at that time we were still not using next generation sequencing.
Right.
We were using something called CGH, so it was less likely to identify mosaic embryos, and in fact it mistakenly resulted in many mosaic embryos being defined as euploid, normal genetics. So it wasn't very good at predicting who would be successful or not.
No, for sure. Not at day 3, because there's a lot less cells to play with, and the whole concept of cells.
There's further development of the embryo and differentiation of cells. Yes.
Right.
So we are understanding that biopsying on day 3 was not that useful. But at the time, that's what we knew how to do.
Yes.
And there weren't a lot of people employing it, because if you do a biopsy at the day 3 at cleavage stage, you're more likely to have problems, or you could potentially damage, because there are risks associated
Absolutely.
with this.
There's a lot less cells, right?
There are fewer cells, so you can damage an embryo, and then you can diminish the likelihood of implantation. And there are actually some good studies that looked at biopsy on day 3 versus biopsy on day 5.
Right.
And does it affect implantation? Yes. If you're biopsying an embryo on day 3, it's less likely to implant than if you biopsy an embryo on day 5. It's just as likely to implant if it's.
Well, plus, I mean, if you're, let's say there is something abnormal, but yet, if you, as they develop, it can self-correct, then it's an inaccurate testing anyway.
If you do it too
soon. Or for the day 3 and so on.
Yes.
Right?
And then also the fact that we have a different platform now, the next generation sequencing, as opposed to the array-based testing. And they actually did studies where they compared the array to the next generation sequencing. And the next generation sequencing is superior because of the depth of reading.
Right. So let me bring it back to the old days.
Yes.
The point about that is there was no real option, so you end up just blindly, well, kind of blindly. It's by eye. You choose the embryo by eye. Ish.
Yeah.
Right.
So it's morphologic selection.
Yes.
So you looked at cells, and you also used the zygote scoring to inform you, so the way that they cleaved over the days, how the embryos grew in culture.
Right.
And then also they were graded based on the number of cells.
Yes.
And then also on the clarity of the cells. Is there what's called nuclear fragmentation, which is essentially nuclear garbage, like junk, penis?
Yeah. Not everybody has it, and not all embryos have it.
Not all embryos have it. But the thing was, at that time, we would sometimes be surprised, because people could have not the greatest looking embryo.
That's right.
Which would do well, because we transfer it. It's what people would have, and we say, well, let's transfer it. We don't know what's going to come of it. And then sometimes they get pregnant. And then other times we transfer these beautiful looking embryos that wouldn't implant. So a lot of the research and development in reproductive embryology is trying to figure out how we can optimally select what's going to get our patients pregnant in the shortest amount of time.
And I'll tell you, I think, if it had been offered to me at that time, it would have saved a lot of grievances, because what I ended up doing was doing an IVF cycle, retrieval, and then doing a fresh transfer, cycle after cycle. Mm-hmm. I had 2 miscarriages in between, but really, had I done multiple retrievals, and by the way, for me, it was because I didn't have that many embryos to begin with. So then, fast forward, it would probably likely require me to do multiple retrievals before I get enough to bank and then actually test.
So that would have been an option for you now in 2018.
Yes, that's right.
And I think that what I, as a woman who's had IVF, have some difficulty with when I'm amongst my peers and we're having these academic debates about whether it's useful or not is, well, it appears that it decreases the time of pregnancy. and it may decrease the miscarriage rate, but women will eventually get pregnant anyway, so
Right.
why bother? And I say, you don't understand what it's like to miscarry. You don't understand what it's like to have 2 or 3 cycles before something works. You don't understand what it's like to say they'll get there eventually. The process, the experience of infertility is one of the greatest reasons why people drop out from care.
100%. And you know, like the most difficult part, you know.
And you know this with all
I
the
know
support
this.
that you give to
Absolutely,
patients, right?
right? And so, for example, you know, it's difficult to do the stimulation drugs, but I tell you, every time, hands down, the most difficult part is that 2-week wait,
Oh, yes.
right?
Yes.
And then getting that no, or even when
Yeah.
you get the positive, the fear of
Constantly that it's not real.
Yeah,
Right.
right?
Yeah.
So to save yourself from having to do that multiple times
Is a gift. Right?
is a gift, I have to say. And
And I think I have to say something else just because I don't know where we are time-wise, but I have to say this. So, even though we have the ability to test them, and we select out the healthy ones, and they're more likely to implant, they are not 100% likely to implant.
thank you. That was our
So
next
I
point.
think I'm following the cues, but it's important. I don't want patients to go away or individuals to go away thinking that I'm going to do PGTA and for sure my embryo is going to implant and I'm going to get pregnant 100%. That's not the case. And it's important for patients to advocate for themselves and ask the questions before they decide that they want to do the testing, because they have to know, am I in the right age group for this to be really useful? What is in your lab's hands? What is the likelihood that you will biopsy and will end up with a normal genetic embryo? That is lab to lab independent.
Right. So meaning labs can't.
The lab matters.
Matters.
And we know that because we look at our data. So we're able to say that in our hands we know that we have an 83% euploid embryo creation per patient. So even in our old ladies and in our, sorry, not old ladies.
Excuse
in our,
me.
sorry.
She just did a major faux pas.
It's a
I'm gonna
document
apologize for her, guys. Okay.
I'm sorry.
She is
I'm
empathetic,
old. There's
really.
no judgment. I am old. But in our women who are over 40, in our older patients,
In our mature patients.
when we are looking at a euploid embryo, we know even with their normal genetic or euploid embryos, they are less likely to implant than even a euploid embryo in a young person. So it's not the same across the board. It's stratified by age. It depends on the lab where you're at, and it also depends on the operators. Are the laboratory technicians, the lab specialists, your senior embryologists, do they do lots of these? Do they have any embryo loss rate? Those are questions that are fair questions for your physician. Physicians know this stuff, but they sometimes don't volunteer the information, not because they're not trying to give you the information, it's just because, you know, we do the best to communicate what we can communicate in the amount of time that we have. But if you want those specific questions answered, go to your appointment with that information, and your doctor will be more than happy to communicate that information with you.
But then, you know what, if you're given that stats or the percentages, you're not sure what to do with that because this is the only place you're going to.
Yeah, but it's not necessarily the only place you're going to, right?
True.
And
Okay,
I
fine.
do a lot of second opinions.
That's true.
I have
That's very
patients,
true.
and you
Yeah.
know, and it goes both ways, right? And
Yeah.
where you go is not necessarily the right fit for you always.
Yeah.
And you might start with me and go somewhere else. You might start somewhere else and come to me, and we know that. What works for one person or one couple will not necessarily work for another couple, will not work for somebody else. So I think it's fair. I mean, it's the year 2018. People are involved.
2019.
Sorry.
Happy New Year!
But yeah, it's the year 2019, so we know that the information exists, and we have these statistics, and we're happy to share, and we like our patients to be empowered. Knowledge is power, which is
Yes.
why we do things like this at night when we have kids and we're trying to fit in homework or whatever. We're like, we need to do public education so that our patients will understand that individualized patient care matters.
Absolutely.
And you are not just a number or protocol. When I trained 20 years ago, 20 some years ago now, yikes, it was a very different way. We looked at patients, we were protocol driven, you're on this age, you come in and this is what you do. Now, we have advanced technologies in the laboratory. We can streamline things in the lab. We can streamline things with protocols. We don't just look at someone's age and their antral follicle count and say go. We put it together like a puzzle. It's individualized patient care. And we add in auxiliary things like acupuncture, naturopathic therapies, auxiliary medicine that will help optimize the experience for our patients. And we're seeing that it's making a difference in outcomes. And now that all this, literature is coming out with individualized patient care and tailoring it to your patient. It's not every person that needs the same dose of medication, and BMI matters, and we should be telling our patients if they are too heavy to lose weight, if they're too thin to gain some weight, because we know that there's an optimal BMI for patients to get pregnant.
Absolutely.
So we know all this information. We need to employ it on a daily basis. We can't just pigeonhole people anymore, and that is the biggest thing that has changed. So having this as a tool to add to the armamentarium of what we're doing to individualize patient care is how it should be employed. And maybe down the line, there'll be a superior test, and there will be a much clearer way, and there won't be the mosaicism, and we won't be having these debates about whether we should or not. And if you do have a mosaic embryo and trying to figure out what to do with it, and you have any questions, you should be speaking to a genetics counselor, just by the way.
And by the way, on that note, some of and you guys might have read this or heard about it, where, this woman and she had these abnormal embryos. They're not abnormal, they're actually mosaic.
They're mosaic, so they have a degree, yes.
Yeah.
They have a degree of abnormality, and not every mosaic embryo is created the same or created equal. There are a percentage of mosaic cells, and then it depends on which chromosomes are involved in those mosaics. That will make a difference as to what the actual recommendation should be about whether it should be employed or discarded or saved or whatever.
But and it is controversial still, even amongst reproductive endocrinologists.
Yes.
But certainly, if you have a trisomy 21, likely, even if it's like 10% or something, they're probably going to ex-nay that, right?
Well, not necessarily, because honestly, not everyone would not want to put back.
That's true. Sorry, right? You're right.
So it's really an individual. It's an individual choice.
Yeah.
But if there are other abnormalities, sometimes there are multiple chromosome abnormalities that are not compatible with life, or those that are compatible with a lifelong illness that would be very difficult for a child to endure. So those are the circumstances in which you really want to have all of the information.
Absolutely.
Right? And a genetics counselor is someone whose expertise, whose genius it is to give counsel about every specific chromosome in every single iteration of that, is the person that you should be relying on for those specific detailed information. For that specific detailed information, your physician can guide you, but the specifics of each chromosome and what that means to have, too many or too few of those chromosomes, that really comes from a genetics counselor, because what it means genetically, you want to know what it means phenotypically, like in life, clinically.
Yes. All right. So take-home messaging: 35 to 40, and repetitive, multiple miscarriages.
Yeah, pregnancy loss.
Okay, and
shortening time to pregnancy.
Shortening time to pregnancy.
Yes, because people talk about the investment ahead of the line, but you know what? If shorten time to pregnancy, the take-home baby rate quicker. So you want to have people fewer IVF cycles when you identify the euploid embryos, and also peace of mind, because if you did an IVF cycle and you know that you have 3 more euploids, you got pregnant with the one, you're going to go, and when you come back in 2 years, you're not going to worry the whole time, because I know what that's like. You finally get pregnant with IVF, and you have these embryos on ice and you don't know anything about them, and you still your whole pregnancy, you're turning in your head and you're wondering what I should. If you know you want more than one baby, it will be a bit of an insurance and calm plan. To bank euploid embryos as well.
Not 100%, but a heck of a lot higher percentage and opportunity, right? So, anything else you want to add? Any words of advice?
You have to advocate for yourself. Listen to things like this that ask the questions and that give you all sides of the story. The internet is a great place, but sometimes blog spaces can be intense. So don't do things that are anxiety provoking, but just knowledge is power, and ask your physician. Your physician is your biggest advocate. Often we get busy, but you ask us specific questions, so I'm more than happy to answer them so that you can use all the knowledge you have and all the technology that we have to have the best outcome when you're presented with infertility.
So meaning too, like if you're the more mature population, you do really want to consult your reproductive endocrinologist, geneticist, to see if you qualify, for
it's indicated if you would be a good candidate for this.
Exactly. And so if you scroll down, I did an interview with Dr. Glacier out of New York, and he was at that time saying, not so much, but he was actually addressing specifically to the older, more mature population.
Yeah, and there
right?
was a
So
trial
he's
that
quite
came out
accurate
since
about
that
that.
time.
Yeah.
Yes.
So
That STAR trial, which was the single transfer of euploid embryo to see the implantation rate, also showed what I just said, the 35 to 40.
exactly. So that's very important to know. So it's not like just necessarily for everybody, hands down. And what was I going to say about this? There was one more point, and now I'm forgetting. Darn it.
I'm not sure. We did a lot of talking.
We did a lot of talking.
Mm-hmm.
So we might have to continue this, and maybe we can talk about NIPT another time.
Sure.
Would that work?
Mm-hmm.
Okay, because people would love that conversation as well.
Non-invasive prenatal testing.
Thank you. See, I forget sometimes. Darn.
Acronyms.
Acronyms. We love acronyms. You guys learn a lot about acronyms when you go through the fertility clinic, don't you? So, thank you so much for being here.
It's my pleasure.
I love it. So good to see. She's like my peeps. Like we're buds.
We're buds.
And this is what it's about, right? Integrative medicine, integrative health, because you know what? We're here to serve you. It's not one, it's in fact, we call it one medicine. It's not,
we're multifaceted.
We're multifaceted. And we're literally here for you, as Dr. Marjorie Dixon said. We both came from work, long day. She brought me dinner. We're chowing down, talking about this, and then being here with you tonight, because this is what we're doing. This is like a little mini volunteer job.
Yeah, but we're happy to do it.
Yeah.
Yeah.
Thank you.
It's a pleasure. Thanks for having me.
Okay, so guys, I normally don't have the screen like this. It's literally on my cell phone, so I'm gonna have to run and like press a button. But before we go, the very last thing is Dr. Marjorie Dixon and myself, we're speaking. I don't know if this is backwards on your screen, but hopefully not. We're at the Canadian Fertility Show, and we're both speaking. What's your topic?
I don't know.
Okay, great.
Stay
Something
tuned.
IVF related.
It's something, yeah.
Right?
Assisted reproduction. But Dr. Wong will put that on the things that you have on Facebook, so you'll know exactly what I'm talking about.
Okay, it doesn't say here. But
No.
okay, fine. Anyway, it is February 23rd, 2019, 9:30 a.m. Oh my gosh, there's a
To
typo.
5 p.m.
To 5 p.m.
We'll tell them they too.
Yes, yes.
That's
Okay. And promo code, guys, you get 50% off when you're watching this. So you punch in CFS capital. What do you call that? A dash? Dash.
Hyphen. It's a hyphen.
Hyphen. Capital A for alive. And then that's it. And then you get 50% off.
50%.
I don't think it's very much. I think it's like $6. Like it's not a big deal.
I have no knowledge.
Okay, I have no idea. But all I can say is this. This is the second annual Canadian Fertility Show. We were both here last year and we both spoke. And it was amazing because I thought no one was going to show up because we were literally there.
Yeah, there was a giant snowstorm.
Giant snowstorm. Giant.
Like almost white out. Couldn't see where you were driving.
But people with fertility challenges,
Get there.
yes. I love the way we're speaking.
Yes, it's true. Dedication.
Dedication, and there were like over 400 people. I was amazed. So hopefully the weather will be better this time and there'll be a lot of people. And it's crazy to me that, you know, you're in this experience and you know that a heck of a lot of people are enduring this, yet you feel so alone. So this is the kind of environment where you can kind of talk to your other peeps. This is a time to get to know other people, okay? As you learn. And talk to someone like her and myself. So if you want to come, that'll be awesome. We'll love to see you there, okay? Have a great night. We'll see you next Wednesday. And I don't even remember what my topic is about. But it'll be awesome.
It will be.
Okay, say bye.
I'm gonna say bye. You're gonna turn it off?
I'm going to turn it off.
Bye.
Oh my gosh, there's a lot of things being said, but oh well, too bad. They
What's
can't.
being said?
I don't know. Oh dear. I can't even turn you off.